Yeah.
Okay.
So please start.
Good evening, everyone. I'm Dr. Akhilesh. I'm presenting you my topic hypomagnesemia under following headings: presentation of hypomagnesemia, approach to determining its etiology, and the management part. So before starting the proper topic of hypomagnesemia, we'll see some common facts about magnesium. Magnesium is known as forgotten cation because we usually talk about calcium, potassium, and sodium. So magnesium is the fourth most common cation in the body and second most intracellular cation intracellularly. The most abundant extracellular cation is sodium, while intracellular is potassium. Normal serum magnesium level ranges from 1.5 to 2 milliequivalent per liter or 1.7 to 2.4 milligram per deciliter. We consider hypomagnesemia when it levels falls below 1.5 milliequivalent per liter. While the symptomatic hypomagnesemia occurs when the serum level less than 1 milliequivalent per liter. Why magnesium is that much important? Magnesium is important because it is involved in various reactions where calcium flux is required. It is a cofactor for various reactions, various enzymes where ATP get consumed. Almost more than 300 enzymes are there in body which requires magnesium for their action. Only 1% of total magnesium is in extracellular fluid. The most of the magnesium within bone, almost 70%, 29% intracellularly, and 1% extracellularly. Out of these 1%, 70% is in free form, which is active, and 30% is bound to the albumin. So we'll use this concept later on. So please remember this, that 70% of extracellular magnesium is in free form. So, how the magnesium metabolism takes place? We take magnesium in the form of vegetables, nuts, legumes, chocolates, and some fruits like banana, grapes, and oranges. It reaches to the intestine, and almost 80% of magnesium get absorbed in duodenum and small intestine. Via blood, it reaches to the kidney, where almost two-thirds of the serum magnesium get ultrafiltrated, and out of which 95% of filtered magnesium get reabsorbed, mostly in the ascending limb of loop of Henle. So it is also important to know that the maximum absorption takes place in intestine and excreted by the kidney, and 95% get reabsorbed in the Henle, loop of Henle. So the first heading of my presentation is the how hypomagnesemia get presented. So the hypomagnesemia rarely occurs as a single deficiency. It usually presents with hypocalcemia and hypokalemia. These two cation also deficient when their magnesium is low. So the overall symptomatology is the combination of these three deficiencies. The cardiovascular manifestations includes prolonged PR interval, prolonged QT interval, which causes Torsades de Pointes, atrial and ventricular arrhythmias, especially in patients with digoxin, and digitalis toxicity get precipitated or aggravated by hypomagnesemia. So the patient who is having cardiac compromise status, uh, it is very much important to maintain his magnesium level to the normal to prevent arrhythmias. In neuromuscular manifestations, they are similar to hypocalcemia. They are lethargy, tremors, fasciculation, ataxia, tetany, and seizure. So, how magnesium is related to other electrolyte abnormality? Uh, uh, there are three things in electrolyte abnormalities like hypercalcemia, hyperphosphatemia, and metabolic acidosis, which causes hypomagnesemia. How they causes hypomagnesemia? When hypercalcemia is there, it increases the magnesium secretion because of the increased calcium load to the tubule. So magnesium will lost in urine. In hyperphosphatemia, magnesium gets chelated. The hyperphosphatemia occurs with the rhabdomyolysis, tumor lysis syndrome, and hemolysis. In metabolic acidosis, there are specific type, either decay or starvation ketoacidosis. If it is chronic, then there is expression of some cation channels on the DCT, which decrease expression of these channels. So magnesium did not get reabsorbed from the filtered fluid. So hypomagnesemia sets in. When this hypomagnesemia occurs, what it causes, we know the magnesium is required to release of parathyroid hormone, and parathyroid hormone is for calcium homeostasis. So when there is decreased parathyroid hormone, there is decreased calcium. So hypocalcemia occurs, and it also causes more ROMK channels opening, and which allows the calcium efflux out in the urine. So hypokalemia will take place. So I already told you that hypomagnesemia usually presents with hypocalcemia and hypokalemia. So we should have remember that the calcium, potassium, and magnesium deficiencies can occur together mostly. So if we found that there is patient having low magnesium, we have to look for potassium and calcium also, and vice versa. How to approach to determine how to approach for magnesium deficiency? There are three battery of tests we do. Magnesium load test to look for the deficient state or magnesium deficiency state, and the two tests, 24-hour urinary excretion and fractional excretion, to know the etiology of the hypomagnesemia, where the magnesium why magnesium is low. So magnesium load test, what we do, we give 2.4 milligram per kg of magnesium sulfate over 4 hours, and we collect 24-hour urine. If the collected urine have less than 80% of magnesium, then we can say the body is deficient in magnesium. And this test nowadays very rarely done, because almost 80% of ICU patients are magnesium deficient. So when we consider that patient have magnesium borderline or lower side, we'll correct it and keep it around 2.5 milliequivalent per liter, rather than doing this magnesium load test. The other two tests, 24-hour urinary excretion, it is done on the 24-hour collected urine, and we calculate total amount of magnesium. If it is more than 2 milliequivalent per liter, then we can say there is magnesium wasting from the kidney. Or we can do on random urine specimen by doing fractional excretion. For this, we require urinary magnesium, plasma creatinine ratio, plasma creatinine, and divided by plasma magnesium and urinary creatinine. We divide this formula by 0.7, because I already told you that only 70% of extracellular magnesium is in free form. If the fractional excretion is above 2%, the normal kidney function, we can say the renal magnesium wasting is takes place. So these are the various causes of hypomagnesemia, either decrease intake or absorption, either increase losses or redistribution. In decrease intake or absorption, we can say alcohol, GI malabsorption, GI drainage, parenteral nutrition, or proton pump inhibitors. This causes a decreased absorption of the magnesium, and hypomagnesemia will occur. Increased losses might be due to skin, kidney, or intestine. In a skin, the burn from kidney, either increase flow to the kidneys, like polyuria or diabetes mellitus, and decreased tubular absorption. It occurs in the various with various drugs: loop diuretic, thiazides, calcineurin inhibitors, cisplatin-based chemotherapy, amphotericin, aminoglycoside, and some genetic disorders like Gitelman syndrome and hypercalciuria syndrome. In intestine, diarrhea can cause hypomagnesemia by increased loss of magnesium. And in redistribution, in hungry man syndrome and refeeding syndrome, magnesium get utilized when we give suddenly nutrient to the fasting person. And in pancreatitis, the magnesium get chelated on saponified. So we can classify hypomagnesemia. We can divide the causes in two categories by using fractional excretion of the magnesium, extrarenal and renal. In extrarenal, we can say GI causes due to decreased intake and the sequestration. And in renal wasting, if more than 2%, fractional excretion is more than 2%, or 24-hour in the magnesium is more than 2 milliequivalent liter, we can say it is renal wasting. So these are the different causes under different subheadings. In GI causes, it may be starvation, decreased intake, malabsorption, diarrhea, prolonged GI drainage. And in sequestration or chelation, I already told you that hyperphosphatemia, it may be rhabdomyolysis, tumor syndrome, or hemolysis. In pancreatitis, there is chelation of magnesium. The citrates can chelate the magnesium. And renal wasting, it may be due to hypercalcemia, diuretics, chronic alcoholism. Alcohol causes there is tubular dysfunction and decreased reabsorption of the filtered magnesium. So the hypomagnesemia will occur. The aminoglycoside, with aminoglycoside, amphotericin, cetuximab, and platinum-based chemotherapies, Bartter and Gitelman syndrome. They are the tubular dysfunction disorders. So let's learn this thing by example. A 73-year-old male, known case of hypertension on chlorthalidine antihypertensive therapy, and he is diabetic. Recently diagnosed with adenocarcinoma of rectum and started on cetuximab and FOLFOX chemotherapy. His routine blood parameters are as follows: his sodium 137, potassium 2.9, chloride 101, bicarbonate slightly on higher side 26, urea is 15, creatinine is 1.5, almost normal. Sugar is well controlled 86, calcium is 7.8, low, and magnesium is 0.6. When we see that the magnesium is low, we consider that magnesium is, we have to know the cause of magnesium. So we did urinary creatinine and urinary magnesium to apply our formula of fractional excision. By using this formula, we found that fractional excision is 16.5%. So 16.5% is very much higher than 2%. So we can say there is renal magnesium wasting. So why this is wasting is happening? So there are two drugs, chlorthalidone and cetuximab, which is causing hypomagnesemia. So we'll hold this medicine and we start on oral magnesium. As the patient came for routine test, so we started oral therapy. Otherwise, we go for IV. So one more thing I want to stress out here, that the hypomagnesemia is present with hypokalemia and hypocalcemia. So if we found that hypokalemia is there, then we have to look for magnesium level also and calcium level also. So the management, the sign and symptoms of hypomagnesemia are reversible with magnesium replacement. Magnesium losses, either due to diuretic or any other drugs, chemotherapy should be addressed and either change. And the route of magnesium repletion varies with the severity of clinical manifestation. There are two strategies for magnesium supplement, either oral or parenteral. Oral therapy is for patient with mild symptoms. We can use magnesium oxide tablet or gluconate glycinate form. They are available in 400 to 800 mg per tablet, which we can use BD or three times in a day. The action is slow in onset with oral treatment, and GI intolerance is the main side effect. While with the parenteral treatment, it is for severe symptoms and patients who are not tolerating oral medicine. Magnesium sulfate salt is available. Either for mild symptom, we can give intramuscularly 1 gram, 6 hourly for 4 doses. With severe symptoms, with severe deficiency, in asymptomatic patient, we can give 4 to 8 gram at less than 1 gram per hour infusion. For in symptomatic, we have to give a slightly rapid over 4 to 5 minute IV. So there are a few other places where we use magnesium sulfate in toxemia of pregnancy. Here, magnesium sulfate is used to prevent the seizure associated with preeclampsia and to control the seizure. It causes neuromuscular blockade and muscle relaxation. So the magnesium sulfate is used. Either we can give, first we give bolus 4 to 5 gram IV in 250 ml NS. Followed by we can give intramuscularly 10 gram divided doses, or we can continue with the infusion at the rate of 1 to 2 gram per hour. The other condition where we use magnesium sulfate is the Torsades point is where the magnesium sulfate is the drug of choice. We will give 1 to 2 grams slow IV over 5 to 60 minutes. And some doctors off-labelly use for preterm labor as a tocolytic. So as we talked about hypomagnesemia, it is also, I added a single slide for hypermagnesemia also, because it is a small topic. So hypermagnesemia is a small topic. It is very unlikely to have hypermagnesemia if kidney function is normal. Hypermagnesemia is considered when serum magnesium more than 2.5 milliequivalent. But the symptomatic hypermagnesemia occurs when the magnesium levels are higher than 5 or 6 milliequivalent per liter. So the cause of hypermagnesemia includes renal compromised patients, either receiving magnesium-containing antacids, laxatives, or IV fluid. Even when we treating hypomagnesemia or preeclampsia, when we infuse excessive magnesium sulfate, then hypermagnesemia can set in. So that's why I added this topic here. And the symptoms of hypermagnesemia include in neuromuscular system, there is muscle weakness, lethargy, loss of deep tendon reflex, muscular paralysis, and respiratory failure. In cardiovascular system, it can cause hypotension, bradyarrhythmia, cardiac asystoles, and complete heart block. So the loss of deep tendon reflex, what we have to assess regularly while we correct the magnesium deficiency. So the treatment of hypermagnesemia include either injection calcium gluconate, Lasix, or glucose insulin infusion. In renal compromised patient, we have to go for dialysis. So I have talked about Torsades de Pointes. It is a polymorphic ventricular tachycardia in patients with prolonged QT interval. The QTC interval more than 440 milliseconds. There are two categories of causes. One is congenital, which is Brugada syndrome. It is a autosomal dominant condition, and sodium channelopathy. Acquired causes include hypomagnesemia, what we are the topic we are discussing, and the hypokalemia is also the cause. Otherwise, the antiarrhythmic drugs class 1C and class C, the erythromycin, terbinafine, cisapride, these are the other drugs which can cause QT prolongation and Torsades de Pointes, where the morphology of QRS complex varies beat to beat. Ventricular rate ranges from 150 to 250 per minute. Torsades usually terminates spontaneously, but frequently causes ventricular fibrillation and sudden cardiac death. So if there is a Torsades de Pointes or prolonged QT interval, we treat it with magnesium sulfate because it is the drug of choice. 1 to 2 gram IV initially or 30 to 60 seconds, followed by repeat after 10 to 15 minutes, or otherwise continuous infusion. We can start 3 to 10 milligram per minute. So finally, my take-home message are in critical settings, hypomagnesemia is very common. Cardiac compromised patients are more vulnerable for arrhythmias due to hypomagnesemia. So we have to more vigilant and keep magnesium level up to 2.5 milliequivalent per liter for these cardiac patients. CNS and cardiac manifestations should be taken care of on an urgent basis via IV magnesium sulfate. While correcting hypomagnesemia, we have to check deep tendon reflex because the loss of deep tendon reflex and lethargy are the first signs of the magnesium toxicity. And in the last, if there is hypomagnesemia, we have to look for hypocalcemia and hypokalemia. And vice versa also possible. If we found hypocalcemia or hypokalemia, we have to check for magnesium level also. Thank you.
You can stop sharing. Thank you. Very nice presentation, Akhilesh. I can say one thing.
Yes,
You
sir.
have a flair for teaching, and mark my word, in the future you're going to become a good teacher of
Oh,
for critical
thank you,
care.
sir.
All right.
Thank you, sir.
So
Thank you, sir.
lot of hopes on you. Excellent
Thank you.
presentation. Lot of effort you've taken to prepare the content. So I appreciate that. Now, you've already said that hypomagnesemia is defined as a serum magnesium less than 1.7 milligram per deciliter or 1.5. That's already said. Now, so I'm not asking you. This is for the candidates. All right. So you will not answer this. And you can always comment on it. Dr. Mita can comment on it. It's mostly for the students. And the best way to reply is to put it into the chat. Okay. Now, my question is, I will start off with easy ones and then they become slightly
Sir,
more
let them
difficult.
raise the hand, because if one person
Oh.
puts in the chat, then everyone else copies the same thing.
Okay,
So
one
they can
second
raise,
then.
there's an option of raise hands. They can raise the
Yeah,
hands
okay.
and then you can.
All right. Then let me make you, 1 second, Mita. Let me just set it up. Ariba has already raised hands. Okay. Mita, I'm making you co-host.
Okay.
Okay. So that you'll be able to see the question answers. Now, we said that when you have low magnesium, Dr. Akhilesh said that you must do the calcium and phosphorus levels also. But he also stressed that you must do the serum creatinine, because if the serum creatinine is elevated, it affects our treatment. How does serum creatinine elevation affect our treatment? So we know that how to correct it if the serum creatinine is normal. But if it is raised, then how will it affect treatment? If you can raise your hand. And
so basically, question is, you want to correct the magnesium because there is a magnesium deficiency.
Vinod
but if the
has
creatinine
raised
is
hand.
high,
Yeah,
Alok
Vinod
has raised hand.
Okay. I saw Vinod first. So Vinod, what would you like to answer? You can just put on your mic and then answer.
Sir, we correct by giving half the dose.
Exactly. So though it is said 30 to 50% of the dose only you give if there is renal failure, especially chronic renal failure, but it's safe to give half the dose. And then the second part is that very frequently you keep checking the serum magnesium. Though serum magnesium does not correlate with the intracellular or the magnesium stores, but you do serum magnesium just to get a trend of how fast it is getting corrected.
Especially in renal failure patients.
Yeah. Now, the next question is, how do you decide when to give oral magnesium and when to give IV magnesium? Saurabh?
Surabhi. Saurabh. Saurabh.
Saurabh. Huh?
Yes, Saurabh. You can unmute yourself.
It's we can give oral when there is no symptoms, and we can give IV when there is a symptoms along with the low magnesium level.
Yeah, that's
It
very
all
true.
depends.
So if the person is asymptomatic, yeah, you can. If the person is asymptomatic, then you can give orally. And if the person is symptomatic, especially if it's moderate to severe, you need to give IV. Now, what oral preparations have good bioavailability? Now, saying give orally is fine, but there are many preparations that Akhilesh talked about: oxide, magnesium chloride, magnesium
Gluconate.
glycinate, magnesium gluconate, magnesium lactate, and they are available in India. So if you know the brand that you would give, okay, how much magnesium does it contain and which preparation, and which chemical, which will you use as the good bioavailability?
Oral.
Okay, Hardik.
Good evening, sir. I guess the citrates, magnesium citrates have a good bioavailability.
Yes, citrates definitely have good. The main thing is that the oxides which are available, not only have they got a high complication rate in the sense of diarrhea and poor tolerance, but they're not good bioavailability, very poor bioavailability. Chlorides are good, lactates are good, glycinates are good. That's fine. Do you know any common brand that you can give to patients? Because it's common. So do you know of any brand and how much magnesium it contains? Afan?
Sir, here usually we give magnesium orotate, magnorate 400.
Okay, which compound is it there and what does it contain?
Magnesium orotate, sir.
No, fine, that's the brand name, but what does
Yeah.
it contain? What is the chemical?
Magnesium orotate, sir. Orotate.
What is the salt?
So salt, magnesium orotate, sir. Brand name is magnorate. Salt is magnesium orotate.
Okay, I'm not aware of orotate. Okay, it's bioavailability. The ones which I could find is magnesium D3 is available. So it's MgD3, which contains 250 milligram of elemental magnesium. Okay, that's
Magnesium
available.
hydroxide is available as ultra magnesium. Of course, it contains some other things, but ultra magnesium karke there's a brand which contains magnesium hydroxide also in that. But again, it comes as an oxide thing. So
yeah, and the other which is very
Sir,
commonly used is
even
Calcimax.
we give
Calcimax has about 100 milligram of elemental magnesium. So, and the dose required is around, how much is the dose per day? Qureshi, Mohammed? What is the dose?
Sir, it contains 400 mg tablet.
So how much is the dose? Dr. Akhilesh has already said in his lecture, in his session. What is the dose of oral magnesium?
800 BD.
How much BD?
800 milligram.
Yeah, in severe cases, you can give 600 to 1200. That is true. In mild cases, probably you can give half the dose. So it will be 300 to 400 or 200 to 400 milligram that you can give. Okay. What is the IV dose of magnesium if you want to give? It's given as magnesium sulfate. What is the regime that is recommended and most popular?
Hiren Nanda.
1 gram QID.
1 gram.
Hiren Nanda.
Or- 1 gram 6 hourly for 4 dose, sir.
No, not really. Habiba?
IV we are talking about. You said it in there about I am what Akhilesh had said.
Yes.
600 grams per day.
By infusion or 4 to 6 gram it can be given.
Okay, I couldn't hear it properly, and maybe
He said 4 to 6 grams.
Okay. Kapil Dikshit?
So we basically give 1 gram IV over 15 to 30 minutes, followed by 1 gram infusion for next 6 hours.
1 gram
No.
for 6 hours. That's very low.
That's very low. Now, you started off right that you can
Yes.
give 1 to 2 grams
Oh, yes.
diluted over 1 to 2 hours, followed by 4 to 8 grams diluted over 12 to 24 hours. Magnesium, best results are the slower you
Slow
give it.
infusion.
So less than over 12 hours is meaningless. You have to give it over 12 to 24 hours. Why is this so? Because if you give magnesium suddenly, the serum level goes up and the absorption of magnesium in the thick loop of Henle is inhibited because of that. So
Yeah, because
this
kidney
is
senses there is a hypermagnesemia.
so the next question is then what do you dilute it? You
Dilute with
dilute it
which?
in normal saline, with dextrose, with half saline. What do you dilute it with?
Dextrose.
With dextrose. That's very true. I don't know who answered this, but it's true. It's
Dr. Takshi.
Takshil.
Takshil, and you finally joined. Congratulations. So now, yes, you dilute it always with 5% dextrose or with half saline. The reason it's extremely hyperosmolar. Okay, and therefore they do not recommend giving it with normal saline. You have to give it with glucose or dextrosaline, but with half saline. The reason I prefer half saline is that dextrose is free water after it is metabolized in the body. The glucose is metabolized to carbon dioxide and water, but critically ill patients have a reduced ability to metabolize glucose, and therefore, and also in hypomagnesemia, the ability to metabolize glucose is reduced because of the effect on insulin, etc. So half saline is good, but dextrose also is a good.
What about diabetics?
Answer. What about in diabetics? No, my next question is partly related to that. Now, if the patient has congestive heart failure, so a patient with congestive heart failure is on chronic diuretics, and you find rightly so that he has hypomagnesemia, how will you manage this congestive heart failure patient with hypomagnesemia?
Afan, Alokik, Vinod.
Alokik?
Alokik, not Itinder. Alokik.
Alokik.
You raised your hand. You
Sorry.
raised your hand.
Sorry. So you can use potassium and magnesium sparing diuretics such as amiloride in these patients.
Very true. Very true. That in these patients, you can use a potassium sparing diuretic. What else? What else is used in such patients where you cannot stop the diuretics? Vinod.
Hardik, you raised your hand.
Hardik?
Yes, sir. Sir, the hypomagnesemia is centrally being caused by loop and thiazide diuretics. So we can avoid those kind of diuretics and we can switch over to other diuretics. Even we can. Hello, am I audible?
Yes, which diuretic? Switch over to which diuretic?
We can give it to spironolactone.
Yeah,
It's a
but
potassium sparing diuretic.
they already said potassium sparing diuretic.
Yeah.
Besides potassium sparing diuretic, which is the drug which is becoming more and more popular?
Ditor.
That is a loop
That's a
diuretic.
brand.
No.
Yeah,
That's
that's
a
a brand.
torsemide. That's a
Furosemide.
torsemide. That is loop diuretic only.
It's a loop
Loop diuretic
diuretic.
it is.
It's going to worsen your magnesium.
It's an anti-diabetic drug. Which anti-diabetic drug?
So probably dapagliflozin.
Sir, it is
Dapa-
DAPA or canagliflozin.
Yes.
DAPA or
SGL2
canagliflozin.
inhibitors.
SGLT2
SGLT2
inhibitors.
inhibitor.
Yes,
Yes.
SGL2 inhibitors are also recommended in these cases.
Sir, and along with that, we can give orally also magnesium supplement.
Yes, otherwise you can give orally also. Then my next question is, just 1 second. What are the manifestations of hypomagnesemia? Akhilesh already talked about it, but he talked about the CNS and the cardiovascular. CNS is fine. He talked about tremors, seizures, migraine, and mood changes. But in cardiovascular, apart from arrhythmias, what is to me alarming and of concern is it accelerates the calcium deposition in the vessels, in the arteries, and therefore that's important. Hypertension, it worsens hypertension and can cause myocardial infarction. The lungs were not mentioned. The lungs, hypomagnesemia causes bronchospasm and therefore may worsen your asthma and COPD. It may not, even if it doesn't present as a frank attack of asthma or COPD exacerbation, it can slightly worsen it. So that's one thing. Second is the endocrine effects of hypomagnesemia. Hypomagnesemia reduces the release of insulin and therefore can worsen the hyperglycemia. And by feedback, even hyperglycemia worsens the hypomagnesemia. And second is osteoporosis. It causes osteoporosis. And therefore, middle and elderly age people, that would be a concern. Now, magnesium challenge test you spoke about. We've done a lot of magnesium challenge tests, and Meeta, you'll be surprised that the magnesium challenge test is based on a study of only 2 normal people in 1959.
And we have done it on so many people.
The study in 1959 was done on just 2 people who for 1 month, I think they were medical students, for 2 months were given magnesium deficient diet. And when they were given magnesium challenge, they retained 30 to 40 or 50% of it. So that's the basis of magnesium challenge test. Now, what is the drawback of magnesium? Of course, it's good because we know that serum magnesium and the blood levels don't correlate at all. You can have a normal serum magnesium in a patient who's severely magnesium deficient, that we are aware of. But do you know that you can have a low serum magnesium and yet the magnesium stores can be normal? So just because your magnesium levels are low doesn't mean you need to replace them. Of course, if you have, as again Akhilesh pointed out in hypermagnesemia slide, that you will not really cause any problem as long as the renal function is okay. So those with low serum magnesium, even if they have normal body magnesium, if you replace it, nothing drastic will happen. Now, what is the major drawback of a magnesium challenge test? That means you do it properly, but you will get wrong reports. Is if you have a person who's got a magnesium losing nephropathy, and since there is no hormone regulating magnesium, it's the end result of your intake, GI intake and your renal excretion. And GI intake deficiency isn't all that common compared to the renal loss. So when you do a magnesium challenge, even if they're magnesium deficient, there's a magnesium losing nephropathy, so your urine will contain a high amount of magnesium, and you will feel that there is no magnesium deficiency.
So would
that,
the fractional excretion help in that? Because that can rule out whether it's a
yes,
renal
so
wasting or
fractional
GI.
excretion of magnesium, I think, is a very good test to differentiate renal from extrarenal causes. And history is extremely important. If you have a reason for a poor intake, like malnutrition, alcoholism, or you have a reason for a loss like diarrhea and diuretic, because the magnesium is excreted predominantly or absorbed in the lower GI.
The
So
drugs is a major thing. We teach, I think all of you remember the all D's of hypomagnesemia. So
Yes.
lots of drug, Akhilesh may put up a big, nice list of all the medications which are very commonly used in the ICU, like including diuretics, amikacin, like aminoglycosides, amphotericin. So it is, and these are very commonly used in the ICU. So important to remember that.
The way I remember magnesium is either there's a problem at this end or there's a problem in the other end. Okay. Here at this end is your alcoholism and malnutrition, that is their poor intake, basically. And in the other end, it's your diarrhea and diuretics and related. So vomiting can also be a cause, but it is less severe hypomagnesemia than diarrhea. But the third you must add is your tissue in between. And there, in the tissues, you have refeeding syndrome, pancreatitis, hungry bone syndrome, you have pregnancy, especially the third trimester of pregnancy, where they tend to get hypomagnesemia. Okay. And then, of course, in renal loss, you can, is there, if you have the tablets and someone is on loop diuretic or thiazide, you can pick it up. But very often it is due to genetic defects. Okay. So how do you pick up if there is where the problem is? And that is by doing the urinary calcium. If the urinary calcium is high, then it is in the ascending thick loop of Henle problem. That means where your sodium potassium 2 chloride receptor act, where your furosemide acts. Okay. And so your Bartter syndrome would come there. Whereas Gitelman would come in with low urinary calcium. Okay. That's your thiazide and Gitelman's would come there. And if you have normal urinary calcium with hypomagnesemia, it's usually due to chemotherapy drugs. What you talked about, the EFG receptor problem, which occurs with the chemotherapy drugs. So the urinary calcium can help pick up where the defect is. And they are talking nowadays of gene manipulation to treat these patients there. And so these are some of the questions that I thought were relevant to the topic. Yeah, and so that is about it. Any other comments that anyone has? I saw that finally Smita could join. Smita, are you there? Could you?
Yes, sir. Yes, sir. It was
Okay.
initially problem joining, but I joined.
Yeah, and could
Takshil to answered.
Yeah, Takshil answered. And
So I just want to put few comments. Number one, Akhilesh, congratulations. I was very much impressed with your presentation. The way you put up the presentation, and it was very lucid kind of a thing. Very few lines or material on the slide. Beautiful use of smart from the PowerPoint presentation, and very impressive. You started off very well, including your take-home message. So it was a nice, excellent presentation. Couple of things I wanted to say, because as your first opening line was correct, it's a totally forgotten cation. So most of the times people don't do magnesium. So when you said if you have a hypomagnesemia, then you look at potassium and calcium. Actually, it's vice versa. If you see that potassium is low and calcium is low, 100% it is hypomagnesemia. Even if your serum magnesium level comes normal, it is hypomagnesemia which causes hypokalemia and hypocalcemia. I just want to share one another thing you said. When we do urinary excretion, 24 hours urinary excretion, I just want to clear it to the other people, that you said it's if it is more than 2 milliequivalents per liter. So you remember that per liter. So if the value comes, whatever value comes, you have to multiply that by the urine output of the whole day. So if the urine output is 4 liters, the value needs to be multiplied by that 4 liters. So that is one important thing. Another is data set. I just wanted to, you highlighted that point already, that magnesium plays a very, very important role in parathyroid function. And just a small 2 minutes, this thing I'll tell you. We had a reference from a village from Aurangabad, a lady who presented to us with chronic tetany, classical. Initially, we thought like she's malingering. The people have treated her with calcium, with vitamin D supplementation, which is normal for the calcium deficiency. PTH borderline, calcium normal. So when patient presented to us and we saw, she actually had a classical tetany. I have a recording of the patient. The moment you give calcium, it will settle down, but it continued for that reason. Then when we realized that probably it's a magnesium deficiency, because she was being treated with calcium and vitamin D for 1 month in the village, and that was the right treatment. We gave magnesium to that patient and all her symptoms went away. We had to give her magnesium IV. Means her storage must be so low. For 20 days, she received IV magnesium, 8 to 10 grams IV per day. So they bought all the magnesium from Mumbai, magnesium sulfate, 50% ampules, and they took it to the village. So that's how this small, it may sound magnesium, but it is extremely important. It can cause a lot of life-threatening complications like torsade. So I wanted to share that one point. You have already highlighted that for the parathyroid hormone, but your application of knowledge comes very, very vital when you start treating the patients. Yeah, but again, congratulations, Akhilesh. Very good presentation.
Yeah, and this is the type of presentation should be there. I was also happy that you included a case there. We should try and include cases in the presentation. Another thing that it just occurred to me is that a practical point that we cannot do magnesium challenge every time outside a research lab, etc. You have to almost assume magnesium deficiencies there in following patients: chronic alcoholics,
so all
diabetics, yes, all people on aminoglycosides for more than 5 days. Okay, so everyone on aminoglycosides for more than 5 days, which is very common. Okay, alcoholism very common. People with liver transplant, okay, tend to have it. People with pancreatitis tend to have it. People with chronic diarrhea, on chronic diuretics, you don't have to waste time even doing serum magnesium, because if it's normal, also the magnesium is going to be low. So it makes sense to replace it. If they're asymptomatic, you do oral replacement. And if they're symptomatic, then of course you will give IV replacement. So that's what I tend to follow. Magnesium, Meeta knows this.
Yeah, we have done a lot of we have done initially a lot of magnesium challenge test cases in our ICU, and it turned out that approximately 90% of the patients in the ICU with normal serum magnesium value, when you anticipate, like if you suspect magnesium deficiency, you give magnesium. That's what we always teach. And when you suspect were all these, which sir also just now said, and we did the test, the magnesium challenge test in those patients, and of the whole group, 90% of them turned out to be severely magnesium deficient. So after that, we stopped doing the magnesium challenge test, and we practically every patient in the ICU, that means, is on magnesium and it may go on anywhere between 3 to 10 days of around 8 to 10 grams, depending upon the renal function. Yeah. So
last question: oral magnesium, how many days do you need to continue? You said 800 to 1600 milligram per day, but for how many days? 3 to 4 weeks. You need to give it for 3 to 4 weeks. Okay.
If it is moderate deficiency and asymptomatic, mild patients, you can give for 5 to 7 days.
Yeah, mild ones you can of course give that. So these were all the questions that we had. I hope you enjoyed the session. We started off well. Next week,
you're raising the hands. You have any doubts?
Correct?
Yes, ma'am. I am having one doubt.
Yeah.
Sir, I'm wanted to ask that how much we are rational by we are doing in ICU day and night, doing serum magnesium to diagnose hypomagnesemia. So are we correct, or we should directly treat?
We are wrong, absolutely wrong, because I told you that you can have normal serum magnesium, okay, with deficiency severe, and you can have low serum magnesium with normal magnesium stores. So they don't have any
Okay.
deficiency.
So
And
if you have yes,
even metabolic alkalosis, how common is metabolic alkalosis in the ICU or metabolic acidosis? That also affects your magnesium levels in the blood. Okay, so
Yes.
it becomes very unreliable. I think that the advantage of doing it is zero.
Yeah, so basically, if you
Just
have a
treat it.
torsad or if you have a preeclampsia or eclampsia or patient who is symptomatic, you will give that. Or say, for example, patient who comes to you with hyperkalemia, extreme hyperkalemia, because of digoxin toxicity, where you cannot give calcium gluconate. Then you give magnesium. So these are straightforward indications. But otherwise, if you have potassium which is not getting corrected, despite say 100 to 150 milliequivalents per day, you are giving IV or plus oral, whatever, or you have hypokalemia plus hypocalcemia, or you have all those conditions which are there. Like sir said, if someone is on aminoglycoside for more than 4 to 5 days, they are going to be magnesium deficient. And how do they present? What is a symptom of magnesium deficiency in patients who receive, which is drug induced? They will start becoming polyuric. You don't have to wait for that reason that they should become polyuric, but that is one of the indication. If patient starts passing more urine despite any diuretic, patient is becoming magnesium deficient when they are on, especially aminoglycoside.